So we are live in 3, 2, 1. Please start. So we are live.
So, a very good evening to all of you. I am Dr. Abhijit Kumar from Zydus Healthcare Limited. First of all, I would like to welcome you all in this presentation on bempedoic acid in uncontrolled LDL-C, unlocking concept and unleashing efficacy. For this, we have our respected speaker, Dr. Johnny J. Kanampilli sir. He is diabetologist, head of department and senior consultant VPS Lakeshore Hospital at Kochi, and he has a vast experience of treating diabetic patients with and also I would like to thank sir that he has spared his time and to take over the scientific session and provide us or we can say enlighten us with his experiences. So with this I would like to welcome sir on board. So welcome sir and good evening.
Thank you, and good evening to all. And it's my pleasure to be part of this. Sorry. Hello. Yeah. It's my pleasure to be part of today's meeting or symposium. And thanks to Zydus team for inviting me to speak on a molecule which is a new introduction to the armamentarium in treating dyslipidemia, which is a great added problem which has to be countered to reduce the cardiovascular mortality, which is the highest or the major cause of death in our diabetic population. Next slide.
Just a second, sir.
Yeah, so we all know very well that, the dyslipidemia is always a major concern for the CV events. And if you look at the slides, you have smoking, you have exercise, you have alcohol, you have hypertension, diabetes, you have abdominal obesity, you have psychological issues, and you have lipids, which is one of the major issues. And combined, put together all, you have the all risk factors. So lipid is definitely one of the major risk factor for coronary artery disease. Next slide. So we all are very well aware that for CVD primary prevention, we have trials and statin is the drug of choice. I'm not going into those details. Next slide. And also for secondary prevention, we have various trials and we know that statin is still the drug of choice. Next slide. But the management of dyslipidemia is high on our priority, and statins are first-line therapy agents. But next, we have some concerns. Do all statin users achieve an LDL-C goals as per guidelines recommended in our practice? Now, the second concern is how to achieve that LDL-C target after maximally tolerated dose of statins. That is what we are going to discuss in today's session. Next slide. So to talk on the first concern, LDL lowering, lower the better and longer the better. Various trials in this slide can, with various molecules, have clearly shown lower the LDL better, and for the longer the LDL lower, it gives better risk reduction. Next slide. So this is the EA's consensus or the guidelines regarding the LDL reduction. This is two guidelines from 2016 and 2019, and you can see that in 2016 the targets were for low risk patients were 115, less than 115, moderate risk was 115. Now it is reduced to 100, and high risk patient it was 100. Now it has been reduced to 70. And very high risk patients, it was 70. Now it is considered you have to bring it even below than 55. There are some lipidologists who still feel that keep it as low as possible. Next slide. So as CVD risk increases, need for reduction for more LDL is important. Next slide. So based on the revised guidelines, how many patients do have control LDL-C, like below 50. So this was the Da Vinci study, a cross-sectional observational study of patients prescribed lipid-lowering drugs for primary and secondary prevention from 18 countries of Europe were involved. Total number of patients were 5,888. Primary prevention was about 3,000, and secondary prevention was 2,888. The objective of the study was to evaluate the impact of this guideline in lipid or dyslipidemia management guidelines on LDL goal achievement. Next. So if you look at this graph, you can understand from this Da Vinci study, all patients, the green graph on the top, the proportion of patients achieving the LDL goal total from the 2016 guideline, it was 54% of the patient. But according to the 2019 guidelines, it is only 33 patients. That means out of 100 people, it's only 33 people who are achieving the LDL lowering. So that is a very low number. Next slide. In spite of statins, so you should understand that in spite of high statins, only 33% is able to achieve the LDL goals. Next slide. Now again, in very high risk patients, you can see that around 39% was with the 2016 guideline, but according to the 2019 guideline, only 18% of the patients achieved the lipid goal with high intensity statins. So there is a definite requirement for an additional therapy to reduce the risk in this high risk patients. Next slide. So what is the clinical benefit on attaining LDL goals? Next slide. So this is another Korean nationwide study which came out in 2020, and I think it is 2022. It's a recent trial, and the total number of patients was about 5,049 patients. And the results of the study, if you look at, 94% of the patients were on moderate to high intensity statins. LDL achievers were only 22%, and relative risk reduction or MACE in LDL achievers were 37% risk reduction was achieved. Relative risk reduction was achieved who achieved LDL targets. So the study concluded that in patients with acute MI, achieving the target LDL levels was associated with lower incidence and reduced hazard of recurrent clinical events. Next slide. So this is to show you the primary endpoint according to the achievement of target of LDL goals. And you can see that as major cardiac and cerebrovascular events can be reduced to a large extent with LDL goals of less than 50. Next slide. So how to achieve this? Once we know that there is definitely a benefit of CV events as well as cerebrovascular events with reduction of LDL goals, how do we achieve this after maximum tolerated dose of statins? Next slide. So this is extension of LDL reduction with non-statin agents, and you can see that with treatment with moderate intensity statin, you have a LDL reduction of 30%. High intensity statin, you get 50% reduction. High intensity statin with ezetimibe, you have 65% reduction. And PSK inhibitors with high intensity statins, it's about 75%, and high intensity statin and ezetimibe, that is 3 drug, PSK, statin, and ezetimibe, it's 85% reduction. But we all know the cost of PSK inhibitors are very exorbitant, and in our Indian setting, many people cannot afford it, and it is an injectable. Next slide. So then we have an alternative of a new drug or bempedoic acid which is ATP citrate lyase inhibitor, a first-in-class LDL lowering drug, apart from the acetamide. So the indication, it is already approved in USA, EU, and now in India. Approval 2020 in EU and US. And indication is reduce uncontrolled LDL with maximum tolerated dose of statin, maximum dyslipidemia, familial hypercholesterolemia, high-risk ASCVD patients, statin intolerant patients whom statin is contraindicated. The dose is 180 milligram oral with or without food. Next slide. So this is just to give you a glimpse of the how this drug acts, or just to know what happens in the body. Now, it has got three sites of action in the liver, in the kidney, and the skeletal muscle. You have to look into it. Now, a bemfoidic acid is a prodrug, and it is made into active drug once it reaches the liver, and then it inhibits the conversion and thereby reduces the cholesterol synthesis, and thereby reduces the LDL in the drug. But the benefit is, in the skeletal muscle, this drug is not converted into from prodrug to the drug, and thereby it doesn't have any action in the muscle like it acts, like the statins, where it has an action in the muscle, and thereby it causes myopathy, statin causing myopathies. So this drug does not cause statin like myopathies. Another thing is, a problem with this, a small issue which you have to keep in mind, is the action on the kidneys, where the uric acid excretion can be inhibited by this drug, and so thereby in people with having chances of high uricemia, there is a chance that uric acid levels can go up. Next slide. So now, regarding the elimination management of patients receiving this drug, half-life is about 21 hours, and 70% excretion of total dosage is through kidney, 5% through the feces, and less than 2% excretion of unchanged drug through kidney. So it is actually, there's no problem in giving in renally impaired patients. But there's no studies in end-stage renal disease. No dosage adjustment is required in minor renal impairment or hepatic impairments, and not studied in severe hepatic impairment cases. Now, all patients, you can use this drug, but you have to, as I said previously, you have to keep in mind the uric acid and check it. If it's going up, then maybe this drug may not be a drug for that patient. Now, prior history of gout, maybe this patient should not be used. Apart from that, patients who are more than 60 years of age taking corticosteroids or other patients on renal failure, history of tendon ruptures, a very rare problem, but then those are the things which they say that you cannot use, and there is no real understanding into what that has the association. We really don't know. Apart from that, there is also a guidelines that on simvastatin, patients on high dose simvastatins and high dose pravastatin, this drug should not be used. But atorvastatin, there's no problem, and the rosuvastatin, you have no problem in using this drug. And of course, pregnancy and breastfeeding individuals, definitely this drug is not being studied, so kindly not use this drug. Next slide. So now we go on to the evidence with this drug. We have 4 trials. We have the Clear Harmony and the Clear Wisdom and Clear Serenity and Clear Tranquility, 4 trials. And the Clear Harmony and Clear Wisdom are patients with ASCVD, about 2,230 patients with Clear Harmony, patients who had 98% patients who had ASCVD, and familial hypocholesterolemia of 4%, hypertension of 79%, and DM of 29%. And clear wisdom is mainly for about 94% had ASCVD, and familial hypocholesterolemia 5%, hypertension 85%, and DM 30%. Now, the clear serenity and clear tranquility was with the patients who had mainly statin intolerant patients, where it was given for primary prevention, and or even ASCVD patients was trial. Now we go into this trial in detail. Next slide. So if you look at the clear harmony and clear wisdom, the type of patients, you can see that there was clearly patients with ASCVDs and with maximum tolerated statins. Additional it was done as an additional therapy. Number of patients I've already said, duration was 52 weeks, and percentage of patients on statin, almost 100% of the patients. And the efficacy endpoint was LDL reduction in both the cases at the end of 12 weeks. And of course, the safety endpoints. Next slide. So you can see that LDL reduction, remarkable LDL reduction, and also the total cholesterol and ApoB reduction was seen in this. Next slide. So about 18% LDL reduction was seen when you add this drug with statin. Next slide. And non-HDL, just go back to the other slide. Yeah, and about non-HDL also you can see 13% reduction, and ApoB of 11%, and total cholesterol of 11%. Next slide. Yeah, the clear wisdom, we can see that the definite LDL reduction of 17% can be seen, and the non-HDL of 13%, total cholesterol of 11%, ApoB of 13%. Next slide. So this is the tranquility study, clear tranquility and clear serenity. As I've said, this is patients with hypercholesterolemia and statin intolerant. This study was on patients and for 12 weeks and 24 weeks. And patients on statin in tranquility was 32%, and in serenity was 18%. And endpoint again, LDL collection, LDL reduction, and overall safety. Next slide. Next, please. Hello, hello, yeah. So if you look at this, you can see that the clear tranquility in statin intolerant patient, there was a 28% reduction of LDL, 23% reduction, and non-HDL is 18%, and total cholesterol 15%, ApoB of 14%. Next slide. And again, here you can see the other study also, LDL reduction of statin intolerant patients. We can use this drug, and 23% reduction of LDL, and non-HDL of 19%, total cholesterol of 16%, ApoB of 15%. Next slide. This is a phase 3 trial of the same drug as an add-on with ezetimibe, and they found an extensive reduction when they added with ezetimibe, and about 36% reduction. You can see that the non-HDL and ApoB reductions, the ezetimibe alone was 19% non-HDL reduction when it was benfoic acid, bempedoic acid with ezetimibe, it was 31% reduction. Next slide. So this is the a CBOT trial which is ongoing, and the results may be out by 2022, this year, December. So we may be having more information on this drug, on the CBOT outcomes. 14,000 patients are on this trial. Next slide. To see high risk lowering in high risk patient and to know the MAZE outcomes. Next slide. So does it have any other effect other than just the lipid lowering? So to look into that, they looked into the inflammatory markers, and they found that the HCRPs, the inflammatory markers, have a good reduction. Next slide. So this is the HCRP reduction. You can see that the clear harmony, clear wisdom, clear tranquility, clear serenity, all showed remarkable reduction of the high sensitive CRP, which is an excellent marker for the inflammation. And I think this is one important point which you have to keep in mind, because inflammation is the root of all the problems. Next slide. So coming to the adverse events, all the pooled analysis from all the trials, they have found that, of course, there is an increased incidence of hyperuricemia and gout. And apart from that, but one good thing was the new incidence of onset of diabetes or worsening of DF was comparatively lesser than placebo. That was a promising result. But however, keep in mind about the gout and the hyperuricemic problems in patients who have already these problems. Maybe this drug is not the choice. Next slide. So to come to the summary of my talk, in uncontrolled LDL, LDL uncontrolled is a major risk factor, and statins is the first choice for all the dyslipidemias. And even after the high intensity statins, we definitely know there are a lot of patients who doesn't reach that LDL goals. So uncontrolled LDL increases that residual risk by 60 to 70%. So that's a very high risk. So we have a new molecule, that's the bemfoidic acid. We have another molecule, that's the ezetimibe. And definitely you can decide which molecule to try, especially in patients who have intolerance to statins. Maybe bemfoidic acid is a good choice. And definitely the reductions, I've already said the benefit of reductions, and it can be used in mild to moderate CKD also. Of course, hyperuricemia and gout has to be kept in mind and monitored on a regular basis. Next slide. Yeah, I think there is some recent trials coming up on 3-drug therapy like PSK inhibitors, like 3-drug PSK inhibitor with statin with ezetimibe have been tried. But now there are a few other studies coming out with bemfoidic acid, ezetimibe, and statin in high-risk patients to get the desired LDL cholesterol reduction instead of PSK inhibitors, which is very expensive in the Indian scenario. This may be an ideal choice. So we have some data coming up recently with this 3-drug therapy. I'm sure that future we are going to see more and more studies with this. And to end my talk, I would like to say that we definitely have a great problem ahead of us with increasing number of diabetic patients and increasing number of younger patients with diabetes, dyslipidemia, with lifestyle diseases, increasing day by day with the lifestyle culture which is going on. And the younger generation is at high risk for all these diseases. And people are dying young with a lot of complications. And we need such newer and newer molecules apart from lifestyle corrections. But to end my talk, I would always say that we have to go by evidence-based therapy and also ethical-based therapy. That means I would like to highlight on those two because this is very close to my heart. With the growing mobile or digital revolution, the post-COVID era, there's about 50% increase of digital usage and digital information in everybody's hand. And we cannot fool the public. We have to definitely go by evidence-based medicine. Otherwise, in the future is not far away where people are going to come back to you and complain or even sue you for not starting medicines which has caused them some kind of a cardiac events, etc. So at the same time, we can definitely give information to the patient and let the patient take the decision. I think the decisions has to be open, and the patient and the relatives have to be given information regarding the available medications. And then it's a combined decision by patient and you, which is the best available drug to that patient to reduce their risk for future problems. So thereby you're clear in your mind and your heart and the patient so that you're safe. And lastly, I would like to add that ethical medicine is the way forward. With the everything in hand, still I think we have to keep very much cost and other aspects in the Indian scenario. Not everything is insurance based. A lot of people have financial issues. So we have to, at the same time, one hand, we have a spectrum of medications. At the other end, we have lot of financial issues for our patients, especially post-COVID era. So we have to individualize the therapy and we have to give the options open and tell them these are the options available to you, but it is your choice. And tell the plus and minus so that you are free of any litigations. And at the same time, we now know that a lot of people think that a lot of doctors are writing medicines with the pressures from various sides. But let's be clear that we are going by evidence-based medicine, and we are also open to their financial constraints, and we are um, genuine in our treatment. Thank you very much for your patient listening. And that is what I would like to share. And it is now open for discussion and your comments. Thank you.
So, so thank you, sir, for this detailed presentation as well as enlightening us with the new molecule, bempedoic acid. So, sir, now we move on to our question answers. We have some questions. So, first question is, can it be given with PCSK9 inhibitors, and what should be the expected result?
Well, I don't think there is a trial with PSK inhibitor. First of all, PSK inhibitor is very expensive therapy. But I don't think there is any problem. PSK inhibitor is an injection, once a month injection or something like. I've not tried PSK. I think the cardiology colleagues will be better to answer that. But I don't think there is any harm in giving methylphenidic acid while the patients are treated with that. There's no problem. But as of now, I know what the trial is. Instead of PSK inhibitor, if we give statin high dose with the acetamide and bempedoic acid, and if the patient is tolerant without any uric acid problems, then about 90% of the patients achieve the LDL targets. Then what is the need for of a PSK inhibitor there?
So, sir, next question is, if we have to prescribe bempedoic acid in patients with hyperuricemia, then how frequently should we monitor the uric acid level?
First of all, I would not recommend to start a patient who is known to have uric acid problems. But having said that, if you think that, with all the other resources in hand, patients, a hyperuricemic patient who's on statins, who is on acetamide, still not getting control, a high-risk patient still not achieving LDL goals, patient is on hyperuricemic drugs, controlled hyperuricemia is controlled, maybe you can give this molecule and check it once a month first. And initially, if it's not going up, then once in 3 months and once in 6 months, and therefore you may be safe. But there are no guidelines. This is just my take on it.
So, sir, next question is, can it be a suitable option for pre-diabetic patients?
Yes, very much. This is a molecule which is shown in the trial where it has reduced the new onset of diabetes. So definitely in a patient because we know very well that statin can induce diabetes to certain degree. So this is a molecule which has shown that it can delay the onset of diabetes. So definitely a non-diabetic patient who has got cholesterol problems with LDL problems and has no uric acid problem may be a good choice. Of course, these are all, it's a new drug, so we have to keep in mind that we have no clear guidelines on it. These are all, each one's trial and error, and you can try it, of course, with the consent of the patient.
So the one last question we have, it is like, how suitable will it be, will bempedoic acid be for Indian population when statin is the first choice for dyslipidemia?
I don't know the cost of this molecule. You'd be able to highlight me on that.
Vinay, what is the exact price of this?
Sir, 24 rupees.
24 rupees.
Yeah. So looking at the cost, I think we should keep the cost, as I said, of course, evidence-based medicine is very important. At the same time, ethical medicine. I practice ethical medicine because we should not be influenced by any other person except our heart and patient. And that is why, it is called a noble profession. A doctor's profession is considered a noble profession because the patient is trusting you as a very close person who will do right to his health, as a very close person, a relative who does to him. So he takes full trust on you. So you have to go with your conscience right and do correct evidence-based and ethical medicine. And if statin is cheaper, and if he is able to only manage with statin, his affordability is less, then use only statin. But if the patient is a non-diabetic and he can afford bempedoic acid, and you want to make sure that he's not provoked to become a diabetic and he can afford it, maybe you can try a bempedoic acid. Other than that, if once the patient is on high dose statin, then you want to still the patient has not achieved the target of less than 70 or 50 LDL, maybe first think of the pros and cons of using an ezetimibe or an bempedoic acid. And again, it can be a triple drug therapy. All the settings are still yet to become as guidelines. So I keep it open. This is my own personal view on the whole thing. I have not yet started using it. So I would urge you that I think along with the company, we can bring out some results, or we can bring out some data in the coming months or year. Thank you.
So with this, we have come to the end of our today's session. So I would also like to thank our participants for making this session an interactive session through their questions as well as their curiosities. And also I would like to thank Sir for sparing his time at this late evening and giving us this presentation. And as Zydus, we also look forward for more such academic sessions and some very good molecules in future also. So thank you once again. Thank you, sir.
Thank you. Thank you.